Good evening, ladies and gentlemen. Welcome to the EICC, the Edinburgh International Conference Centre. My name, for those of you who don't know me, is Elaine Miller, and I'm one of the Business Development Managers here at the EICC. I'm absolutely delighted to welcome you here this evening to our EICC Live Talk, which is our series of free public talks. Just to get a little bit of housekeeping out of the way, first of all, there's no planned fire alarm this evening. So if the alarm does sound, can I ask you please just to follow the signs and exit the building as quickly as possible. And for everybody's information, we are filming this evening's EICC Live. For those of you on social media, I would encourage you to share your thoughts and post using the hashtag EICC Live. Hopefully to try and keep the conversation going and passing on your thoughts about tonight's talks. We do have a commitment to community engagement, and this is all part of the EICC Live, which brings people together to educate them and hopefully to inspire them as well. Since its launch in 2019, the EICC Live has hosted a huge range of topics, and that's everything from the future of healthcare to sports endurance to banking to neurodiversity. But tonight I'm absolutely delighted that in association with Edinburgh Napier University and the European Society of Cardiology, tonight's theme is a healthy heart, which is obviously important for all of us. Where you'll hear lots about the changing policy around social and environmental factors and how this can improve our heart health. So to get us kicked off, because you really don't want to listen to me all evening, I'm going to ask Liz Neubeck from Edinburgh Napier University to come on stage and introduce our speakers for this evening. Liz, over to you.
Thanks very much, Elaine, and it's really lovely to see you here tonight. I would just like to thank our speakers for coming along, giving up their time, and for all of you for coming to listen to our first talk as the Edinburgh Napier University Centre for Cardiovascular Health in partnership with the Association of Cardiovascular Nurses and Allied Professionals, and our conference starts tomorrow. So we're bringing a huge number of delegates to the city to hear about heart health and how we're trying in Scotland to improve heart health through policy. So without further ado, with one bit of further ado, I would just draw your attention to the British Heart Foundation stand at the back. The British Heart Foundation have supported pretty much every researcher I know. Certainly, I would imagine that most of our speakers at some stage have had support from the British Heart Foundation, and I myself have had support from the British Heart Foundation. So we really value their contribution to the research environment. And so if you would like to make a small donation, we would be very grateful. So now, no further ado, I'd like to invite our three speakers. And while you make your way up to the stage, I'll just tell you a bit about them. So we've got Professor Adrian Davis, who is Professor of Transport and Health with the Transport Research Institute at Edinburgh Napier University and the Centre for Cardiovascular Health. And his work focuses on the health impacts of road transport, the understanding and importance of health by transport planners, and the application of science in selecting which policies and practices most support health-enhancing travel behaviours. So please come up, Adrian. And joining Adrian, we have Dr. Mark Miller, who is a reader in air pollution and health at the University of Edinburgh. His research investigates the health effects of air pollution, in particular mechanisms by which inhaled nanoparticles have a detrimental effect on the cardiovascular system. Your research findings, Mark, have received extensive coverage in national and international media, and so we're very honoured to have you here tonight. Please come up and join us. And our third speaker tonight, last but by no means least, Professor Matthew Bailey, who's Chair of Renal Physiology at the University of Edinburgh, and his research focuses on hypertension and renal disease, in particular investigating how the high salt intake in foods we eat lead to damage of our cardiovascular system. So I guarantee all of you going out for dinner tonight will be seriously looking at the menu afterwards. So please come up and join us, Matthew.
Okay. Good evening, everybody. I'm going to try and canter through these slides. So my title I've given myself is healthy transport, CVD prevention, at least the policy looks right. And I'll try to come to that, but hopefully some of the things I'll talk about will come along in the questions and answers. I'm just hoping that, yes, there's a double-decker bus. I'm going to explain a double-decker bus hopefully in a minute. But, and if we had more time, I'd ask questions of you to make it more interactive, to say, tell me about this person, who is this person? So one of the great grandfathers, or one grandmothers for that matter, of public health epidemiology, I don't really have time to explain epidemiology, but I expect quite a few of you probably know what that is Jerry Morris, or was Jerry Morris. He died aged 99, and Jerry did a number of really important studies in his life. He spent most of his academic life at London School of Hygiene and Tropical Medicine. Sorry, there's a bit of a description about epidemiology, but I'm going to go fast. That's Jerry in later life. But one of the things he did, and I just wonder if anyone put up their hands who know anything about Jerry Morris and this wonderful thing he did, which was published in the Lancet in 1953. No hands? Yeah, oh, actually, that doesn't count. A member of the centre. 2, yes, sorry. Right, okay. So Jerry Morris did a wonderful thing in the 1950s, which was to look at bus drivers and bus conductors. And this was at a time when we really didn't know that much about heart disease, relative at least to what we know today. And so he had this lovely controlled experiment where we have very few abilities these days to do the sort of thing that Jerry did. But anyway, he looked at bus drivers and bus conductors. Now, think, obviously, what's the difference? And he looked at the fact that the bus drivers sat for 90% of their time in their cab. I always think, what do they do for the rest of the time? Did they run around the bus? No, they didn't. And the conductors, though, importantly, climbed between 500 and 700 steps per shift. It's kind of like going to the gym and getting paid for it, I suppose, but I'm sure they probably didn't think of it that way. And so drivers sat for 90% of their time. And this was one of the first studies in the world which showed conclusively that coronary artery disease was a major factor of a problem for the drivers, and that the conductors had half of the coronary events that the drivers had, controlling for other confounding factors like diet and smoking and all these things that you need to control for. So that was one of really the first in the world. And there have been thousands, if not hundreds of thousands of studies that have really followed on from Jerry Morris's work, including in America, his kind of junior Paffenbarger, who wrote a lot of the follow-on studies in the 1960s and 70s. What's really interesting, and anyone knows about the history of science and medicine will have heard of Thomas Kuhn, for another reason that I say, put your hand up and tell me, well, everyone thinks about paradigms, and it was about paradigms because he invented the idea of, or used the idea of paradigms. But Kuhn pointed out in his book on the history of the scientific revolutions that, that often when people do the paradigm breakthrough, their colleagues and fellow scientists don't believe them. So this is exactly what happened with Jerry Morris. No one believed him. They thought, what? So he spent the next 10 years looking at postmen's heart and post-women's hearts, but it's largely post-men. And you can guess what was going on there. He looked at the postal workers who went out and delivered them out on foot and by bicycle, and he compared them with their colleagues back in the base having a sedentary work environment, controlling forward confounding factors. And what did he find? He found exactly the same thing. So it kind of started on a bus. Kind of the stuff we're thinking about in terms of cardiovascular disease and coronary artery disease. So it's also a nice one for me to introduce the whole thing about connecting road transport with public health. So that's one of the introductions. But one of the important things for me in my work, and I don't just work on active travel, all parts of it, encroach a little bit into Mark's area about air pollution, but then he's the deep scientist, so I don't go too far. But it's focusing on active travel. And of course, one of the things about physical activities that we were designed as hunter-gatherers. That's what we're designed to do, except what we've done now is get in a car and drive to Sainsbury's to go and do the hunter-gathering, and so we don't get the physical activity. And so physical activity has been declining for a long, long time. In fact, it's been declining before the Industrial Revolution, but I put from kind of the 60s onwards, because that's particularly when car ownership really took off in the UK. It took off a lot earlier, 40 years earlier in the US. But it took off in the 60s here. And of course, what human beings do, Homo sapiens don't say, I've now changed my commute from walking or cycling to a car, so I'll go swimming in the evening instead. They don't do any of that at all. They don't do anything to recompense for the loss of the physical activity that they had before. And we've seen that in studies all across the world, how damaging that is to health. So Jerry Morris also invented the phrase in 1994 called physical activity is the best buy in public health. If we only had enough money to do one thing, and it's hard to just say only do one thing like cut out smoking cessation work or anything else, but if you only had money to do one thing, the most economically effective thing would be to focus on physical activity. And then when we think about physical activity, and here is why Adrian's involved, is that because the principal thing that we do as Homo sapiens is to get up and walk. The first thing we want to do when we're born is to start to crawl and to walk, and the last thing we want to give up in the aging process is walking as well. We want our independent mobility. So walking, and particularly in cities, in urban areas where many people live, many of you may think, oh, I can't cycle because it's far too dangerous, which is possibly true. It's all over-egged, actually, but it's still perceived to be dangerous, and that's the important point. So until we change the environment, then lots of people will not take advantage of the physical activity benefits they could get, which are very significant with cycling because you raise your heart rate to more than 70% of VO2 max. But walking and cycling are the obvious ways, particularly in cities where distances are short. And we know the crazy fact that nearly half of journeys are under 2 miles. You know, and that's about 40% of car journeys are under 2 miles. So people are doing lots and lots of short trips. And we need to substitute them. We need to substitute them quick because of climate change. And I'm going to come towards that in a moment. Putting it on a wider landscape, and I want to just pull out from just CVD for a moment, there are lots of reasons why we should be trying to encourage more people to be more physically active, and these are just sustainable development goals. So there's decent work and economic growth, and how we get to work, of course, good health and well-being, and it goes on. And there's a lot more. But the sort of stuff that we've been doing the last few years has really just proved what Jerry had first identified and then was followed on by others. And there are lots of studies which look specifically now, I'd say in the last 20 years, we've had a torrent of international studies looking at walking and cycling as physical activity and just showing that what we call all-cause mortality, death from all causes, is significantly lower amongst people who walk significantly and who cycle significantly, because the heart is a muscle, and if you don't use it, then it gets flabby, sort of. Yeah. So here's a study, and I always put this one up on them in Edinburgh because Paul Kelly works for Edinburgh University, so it's a lead author of that, and it's just typical, a systematic review, meta-analysis. It's really robust science to show that actually this is real, that actually if we do get more people to be able to choose to actively walk and cycle, then actually it's better for population health. We want populations to be healthy, and this is one of the easiest ways, if we can get the environment out there, to be better for people to have improved heart health and everything else. Now, other associated areas are things like weight gain, because this is a big area of research and a worry that populations across the Western world are putting on weight. Some of that is directly due to the fact that, as I mentioned earlier, people substitute walking and cycling and public transport use for car. Over time, their weight goes up, and there was a nice poster years ago which said, will my bum get bigger in this? And it was a picture of a woman getting a car, and I mean, that's a bit derogatory in a way, but the point is real in the sense that if people don't then find another way to get physical activity, yes, you are going to put on more weight because you've just taken out the opportunity for routine physical activity. So there are plenty of studies. This is from the Lancet series talking about weight gain. There was an early study from China with mass motorization taking place in China that showed that the people that moved from active modes to sedentary modes put on statistically significant weight gain, etc. And all of this negative stuff is a problem for heart health. So we just need to find ways to actually turn this around. When we look at countries where, and it's like we say, we go on holiday to go to countries where they've got decent transport systems. Scotland's better than England. I've just come from England, and it's even worse than here. But we tend to look, when we look at walking and we look at cycling, we know the places that provide for walking and cycling, and I could be stereotypical here and just pick Switzerland for walking and the Netherlands for cycling. We know that lots of people will do it and build it, and they will come. Did work in the Netherlands when the Netherlands had to turn around their transport policy as part of the oil embargo problem in the early 70s, when they had to reduce their use of fossil fuels. So we know we can actually do some of these things. We can change the built environment, particularly to make it more conducive and supportive for people to choose to walk and cycle, particularly from a young age. And I think the important thing is about from a young age, let's get the habits right rather than have to try and change them later on when people become sedentary. So one of the first things you need to do is to ensure there is a safe route for every child to be able to go to kindergarten and primary school, and the habit is there and the environment enables them and their families to feel that that's an okay thing to do. We often worry about risks, and here's a slide showing multiple studies, but the key point about the slide is that the physical activity benefits far, far, far outweigh the disbenefits from the pollution and the other things, until actually, if Mark had gone first, I might have had to change this slide because of what he might say, but I think the international evidence is still on my side, except for in some Asian countries where really pollution levels are so ridiculously high in cities. So, taking a breath. There are other wider areas. I actually don't want to focus on this very much, but we do know that one of the wider benefits of physical activity is well-being benefits, and that's to do with endorphin release in the brain through physical activity. That's not something to be sniffed at. We find in we did a review, I don't know if I have a pointy thing on there, so I won't try. We did a review a few years ago in 2020, looking at it, it was very clear the people that are happiest on their commutes were the people that walked and cycled. Now, some of that is hard to organise because perhaps wealthier people can live closer to work, and so there are inequalities built into the system there. People who haven't got less money have to live out in the suburbs and commute in, and they can only commute in by car because the transport system's a mess. So there are some issues there, but we do know there are lots and lots of benefits if we can get people to choose to be physically active. One of the few points, I think we were just chatting before the talk start, one of the few positives in all of this is e-bikes. Forget about e-cars and vehicles. I don't want to hear about them. They cause lots of problems and people comfortably think they're the answer. They're not the answer. But e-bikes possibly are the answer. Now, unfortunately, there's an economic skewing here because it still costs quite a lot of money, but everyone I know that's ever got an e-bike never wants to give it back. You know, it irons out the hills. It means that when they say I'm not fit enough, which a lot of people do say about cycling, it doesn't matter because you can just turn up the control a bit more and it will do the do. So there have been lots of really interesting studies in the last few years about e-bikes. The one I'll pick on is Ashley Cooper's team at Bristol University, which focused on people with type 2 diabetes. Now, type 2 diabetes, as most of you will know, I'm sure, is a lifestyle condition. It's something you don't actually necessarily have to have. It's something because possibly you put on a lot of weight and other things have happened in your life which are not good for your body, which have led to type 2 diabetes. Type 2 diabetes is, I have to be careful of the scientists on the words here, is virtually reversible. You can become non-diabetic, essentially. People in Ashley Cooper's study, were some of those who became e-bike users essentially were not diabetics by the time they'd finished being on the program, and that is an incredible achievement. I'll have to be careful with caveat on the words I've just used there in the science. I need to go back to the actual paper, but we've got the good evidence there that worked. It really worked. So moving towards a close here, if you want to look at the evidence on what to do, here's the 2022 walking and cycling stuff from WHO Europe. So you can go online. My last slide is a link to all these, and I'm hoping organisers that people could have the slides. I got the nod on that. So you can go and look at what WHO, the World Health Organization in Europe, says for what we need to do. This in Scotland, and this refers to my bit from right at the start of my talk about where we are. The policy looks right. In Scotland, on paper, we have the best policies on climate change, or one of the best in the world, which is fab, sort of, but and we've actually got a really important target. We've got a target to actually reduce car kilometres travelled by 20% by 2030, which is a staggering target. How we're going to do it, I actually don't know. My stock answer is we throw the kitchen sink every single thing that we know in the transport arena that we could possibly use, from road pricing to school street closures to parking. Parking's a very good one. If you can't park, you don't travel. But this is evident. This is the sustainable transport hierarchy here, where walking and wheeling is at the top. It's what we should be doing, but it's not what we're doing. So how do we get to change that round? And that's really a very big question. We don't have the answers. Scotland is still, I'd say, in a very strong position relative to the rest of the UK, which perhaps isn't saying that much, but is in a relatively strong position of having the target, and the Transport Policy team and Transport Scotland, or at least some parts of Transport Scotland, are really working hard to try and make that a reality. And if that is a reality, and part of that is the free bus scheme for people under 22, which I think is a bloody good thing in that it may stop people from becoming habitualised into car use as young people. It may also reduce their physical activity, unfortunately, for those who were previously going to walk, which is one of the downsides. So this is the stuff about the government target. So 20% by 2030. How do we do it? Well, the ambitions from Transport Scotland are we need to reduce the need to travel, because that's one of the really easy things. We've kind of seen how that works through the pandemic with people working at home and going to work to the office perhaps far less often. Reducing the need to travel, live well locally, switch to walking, cycling, public transport, and combine trips or shared journeys where car is still necessary. We have to do a revolution in the way that we have been brought up to think we just pop in the car, to going, no, that's not the way we do that anymore. Now, I can't see that going to happen without a big stick, so that's kind of prejudging some questions that might come on that. Just finishing off, let's make the world a better place for nothing. I'm quite happy to make the world a better place for nothing, but there are some really good reasons for making the world a better place, which do ultimately improve heart health. If we all become a bit more physically active and do the right things, we can actually improve the environment so that people feel happy to walk and cycle. I know there's a lot of words on there, so sorry for that. But I do think beyond the joke of the cartoon, that actually there's a lot of evidence out there that these are the things we need to do to make the environment a place where people feel able to choose to travel actively. If you're interested, and maybe if you suffer from, you can't sleep very well at night, then you could read my Essential Evidence series. So these are one-page evidence summaries for people that don't have access to academic journals in universities generally and other places. And I try and summarise for practitioners, really, people in local government who don't read peer-reviewed papers as well, don't read academic things, just a one-page summary to give them the evidence. And I'm always wondering, why don't colleagues in other parts of academia do exactly the same? I wish they would. That's a nudge to my colleagues on the stage and elsewhere, actually. So I do those. You can find them on the Edinburgh Napier site. And my final slide is just the link so you can actually get to all of that. So thank you very much.
Thank you very much, Adrian. You've nicely set the scene for me to try and cheer you up a little bit more. I thought we were having a joke before we came on stage that we were going to try and depress you as much as possible be here, but I thought that was positively uplifting, actually. Maybe that's just me, but I'm going to bring you down a little bit. So I'm going to talk to you about air pollution and why it's not good for our health. Now, as I said, I'm going to try and bring you down as much as possible. Why are we worrying about air pollution? I mean, surely we've got enough things to worry about without air pollution. I mean, we've had coronavirus, we've got climate change, we've got the economic crisis that's going on, we've got the risk that these jokers might come back and haunt us. You know, why bother talking about air pollution? So I'm going to tell you why I think we're going to bother talking about air pollution. Oh, it's got a life of its own, this one. Okay, I'll put the whole slide up here. So here's some of the main reasons I think we need to worry about air pollution. Firstly, air pollution affects everybody here. So it's not just the elderly, it's not just people with a heart disease. Those are people that are the most at risk, but actually air pollution affects everyone. It doesn't matter if you're younger, you're old, you're healthy, or you're someone with a health condition. It even affects us really early in our lives, just as a child. It actually affects us while we're in our mother's tummy as unborn. So this is a real problem. One of the reasons, other reasons, is that air pollution affects all our organs. Now, we all think that air pollution, we breathe it in, so it affects our lungs, and it does do rather unpleasant things to our lungs. But actually, over the last sort of 10, 15 years, we're starting to see that air pollution affects more than just our lungs. It affects our heart and our blood vessels and our blood. That's what I'm going to talk to you about tonight. It affects all the other organs of the body as well. One of the other reasons is that 90% of the world's population live in air pollution that's above the World Health Organization guidelines. And actually, these have just been revisited just recently, and actually that figure should probably be 99.9% of the world's population live in air pollution. And you can perhaps see from this slide here, the darker colours are where we have higher air pollution. So clearly the air pollution is a problem in some countries more than others, but we shouldn't be complacent here in the UK, even though we have modest levels of air pollution, because there's no safe level. So it doesn't matter how low you go, if there's any air pollution in the air, it's going to cause harm to the body. But perhaps the most consistent thing that convinces people of why we need to worry about air pollution is when we talk about air pollution and death. And actually, this is the statistic that I find really staggering, no matter how many times I present it. And that is worldwide, air pollution is responsible for more than 7 million early deaths every single year, which is really staggering numbers, and that's above a lot of infectious diseases like malaria. It's on a par with smoking. It's a real issue. And just to emphasize this a little bit further, I'm going to show you just a little bit of data. I'm going to try not to show you too much data, but there was a study by a group called the Global Burden of Disease Groups who do big population studies. And they basically listed all the different risk factors for all the different causes of deaths. And they listed the top 20 here. Don't worry, I'm not expecting you to read the small print. But here's air pollution. It's right up there. It's number 5 on league tables. It's actually number 4 now if you look at the more recent data. It's the number 1 environmental risk factor for early death and for disease. Now, the other reason I want to tell you about this study is it had this graph in here. And again, this is the deaths from air pollution. And you can see that this is the deaths just from outdoor air pollution. This is in the region of about 3 to 4 million in 2015. And I like this graph because it's different colours, and the different colours are the causes of the death. And you can probably see that the majority of the deaths that are due to air pollution are due to this grey and pink colour, and that's cardiovascular disease. So it's not the lungs, the effects of air pollution in the lungs are a problem, but it's cardiovascular disease in particular that's worrying. But I'm going to come back to that in a little second. But firstly, what is air pollution? Where's it coming from? Well, it's coming from lots of different places. Lots of different sources of air pollution. Some of them are natural, a lot of them are man-made. And because it comes from lots of different places, it's made of lots of different chemicals. So when we think about air pollution, it's this huge mix of rather unpleasant chemicals. Now in the science, we tend to categorize it as particles and gases. And all of these different particles and gases have the capacity to have harmful effects on the body. But I want to talk about the particles in particular, because it's these ones that we're especially worried about. When we talk about the health effects of air pollution, it's the particles that are the most concerning. So why are particles an issue? So particles, as I've said before, comes from lots of different things. They're made up of different chemicals. These all affect the body in different ways. But also particles are different sizes, and size is important. No matter what people tell you, size is important. So we tend to actually measure particles in the air by two things that we call PM10 and PM2.5. So the PM stands for particulate matter, and the 10 is the size of the particles. So the 10 is actually 10 micrometers, so that's less than a millimeter. So in this diagram here, we have a human hair, and you can see you can line up 5 of these PM10 particles in the human hair. And then there's an even smaller particle called PM2.5, and these are even smaller still. So they're about the 20th of a width of a human hair, so completely invisible to the human eye, pretty hard to see even under a microscope. And the reason I want to tell you about those things is that's what you'll read in the paper, because that's how we measure air pollution in an environment, and that's how we regulate it in an environment. And you can go to various websites and you can look at your different area and you can see what the levels of these different air pollutants are in your area. So this was some data from St Leonard's, just down. You can see the air pollution was good that day. Maybe now that rush hour has just finished, it might not be quite so good, but it was certainly good. We've got lots of smiley faces this day. And actually, that probably brings me on to a point. Air pollution in Scotland, we still have an air pollution issue, but actually it's pretty modest compared to the other countries, and even compared to the rest of the UK, levels of air pollution are relatively modest in the UK. Also, what this graph is showing here, and I'm going to highlight PM10 and PM2.5, is if you look over the last 50 years, these levels of these air pollutants have been falling steadily. That's slowed down a bit recently, but they're still falling. So that's good news. So why do we need to worry? Well, the reason we need to worry comes back onto what Adrian has been talking about. And this is the same sort of graph over the same sort of period. And you can see this is actually the numbers of vehicles on UK roads. And you can see it's been increasing quite substantially. And with these vehicles comes this. It comes the exhaust that comes out of the back of it. And in this exhaust is an even smaller particle. So it's a particle that we refer to as ultrafine particles or nanoparticles. And these have an even smaller size, which I'm going to just show you just in the next slide here. If you want to know how small these particles here, this is basically like a very small ruler that we'll see, and it's going all the way down from a hair, going smaller and smaller and smaller until we get down to molecular size. And if I put in the nanoparticles that come out of your vehicle exhaust, they're right there at the bottom. So these particles are smaller than a virus, smaller than coronavirus, for example. And why is that important? Well, one of the reasons is because they are so small, they go into our lungs, we breathe them in and they go deep down into our lungs. Because they're so small, they don't actually weigh that much, but actually they have this huge reactive surface area. And on the surface of these particles, there's hundreds of thousands of different chemicals that can interact with the body. But yet, because they're also so small, the way we measure particles in the air is this PM10 and PM2.5. That's how much they weigh. So actually, if we're looking at these websites and we're looking for levels of these aren't really telling you much about what comes out of a car exhaust. And as I've said before, is vehicle exhaust is especially rich in these, and especially one type of vehicle exhaust in particular, and that's diesel exhaust. And that is probably where we started our research. So back in 2005, we started to become aware that diesel exhaust was a major problem. And so we wanted to understand what are the health effects, and because I'm a cardiovascular scientist, we wanted to know what the health effects are in the lungs, sorry, not the lungs, the heart. I'll get that right, I should know. On the heart, the blood vessels, and the blood. And so we started off with two rather talented cardiologists. I would never say that to the face, but two talented cardiologists called Dave Newby and Nick Mills, and with funding from the British Heart Foundation. And we collaborated with researchers in Sweden and Netherlands, and the reason is they have this setup here. So they have what essentially is what we call an exposure chamber. So we have a poor unsuspecting volunteer who we make cycle in a box, and we expose them to exhaust. So this is an idling diesel engine, and the exhaust goes up through the pipes, through the various pipes, through the wall, into the box. What I should point out, though, is this is not as bad as it sounds. So this box doesn't fill up with black smoke. The key word here is dilute here. And we dilute the exhaust with filtered air, and then we can set the levels to whatever we want to look at. So in most of our studies, we're going to do studies where we expose people to 1 or 2 hours of diesel exhaust at levels of what it might be if you're cycling in very heavy traffic. So view this a bit like you're cycling alongside of a motorway for 2 hours. And then after that, we take our volunteers to our clinical research facility, and we can measure a whole range of different things. So this is one of the volunteers that didn't make it. We asked them to lie down. We asked them to lie down so they can be very still, and we can measure, for example, how their blood vessels are responding. So I'm going to show you some data from 15 healthy people, and we're measuring how well their blood vessels can relax in their forearm. Because blood vessels, they aren't just tubes, they're an active organ. They contract and relax, and that's how they control the flow of blood around the body. And this is the data that we see here. So we stimulate the blood vessels, and when we stimulate the blood vessels, it makes them relax. And when they relax, it means more blood can go into the arm, and so you can see an increase in the forearm blood flow. So the blue line is when the person has been breathing in clean air for an hour, and the red line is when they've been breathing in the diesel exhaust for an hour. And it basically shows that this is these vessels, they can't relax as well as they should be. And actually, so this inhibition here, so this sort of decrease in how well these blood vessels can relax, this is really substantial. This is the sort of thing you would see from a non-smoker compared to someone who's a lifelong smoker. These effects, they happen pretty quickly, so within 2 hours of having the exposure, but perhaps even worse, we invited these participants back the next day. Oh, I'm getting trigger happy again. We invited these people back the next day, and we could still see these effects. So these are big effects on our blood vessels, which are still long-lasting. They're lasting for at least a day. And although I don't have time, I've only got 15 minutes, and I'm probably gone 5 minutes over that already to know. So I'm going to summarize just 10 10 years of research in one go. And that's really that when we thought we'd see some effects on the cardiovascular system, but actually we saw lots. Just this short exposure to diesel exhaust, it had detrimental effects on the heart, the blood vessels, and the blood. So if you have a healthy person, all these effects would make you more likely to develop cardiovascular disease. And if you're someone who already had cardiovascular disease, it would make you more likely to suffer from a heart attack or a stroke. I have no idea how I'm doing for time, but I'm going to give us these slides regardless. I think we've locked the doors of the room. How is this happening? Okay, and I just want to spend just a little bit of time there, because actually if we understand how it's happening, this convinces people that this is a real effect. It lets you know who is the most harmful, who is the most at risk and which pollutants are the most harmful. So this is a very thin slice of a lung. So the white is the air spaces of a lung and the grey is the lung tissue. And I'm going to highlight the blood vessels in red. And I want to draw your attention just to this area here, this very thin barrier of the lung, so that when we have the gas in the lung, the gas oxygen can quickly go into the lung, go into the blood vessels, so that the blood can get oxygen and carry it around the body. But actually, remember, these particles are the size of viruses. I've drawn these on here because they'd be too small to see otherwise. So can these particles do the same thing? And this is something that we wanted to study for a little while. And so actually studying where these particles in the body is pretty difficult because they're quite small. Once they get into different areas of the body, they're diluted in the body. But we had a way of doing this, so we took these very small ultrafine particles and we asked people to inhale these particles through a face mask with tubing for 2 hours. And then we looked to see if we can measure them in the blood and the urine afterwards. And this is some of the data that we could see. And even after 15 minutes of the exposure finishing, we could start to see these particles appear in the blood. After 24 hours, all the participants had these particles in the blood. And rather, even more surprisingly, we invited these people back 3 months later, and these particles were still in the blood. So not only are they getting to the blood, but they're circulating around the body. Where do they go in the body? Well, we were lucky enough to recruit a few patients who have had a history of a stroke, and the reason they've had a stroke is they have disease in the major artery of the neck. And so these patients were willing to inhale these particles the day before they had surgery to remove some of this disease from the major artery, and they donated the disease, and we can scan it with our lab methods, and again we could see these particles in this area of disease. So these particles are not just getting into the blood, but they seem to be localizing to areas of disease, the areas that are going to cause the most harm. I have been talking too long, so I'm going to really race through this just now. We've basically invented the perfect weapon. The diesel exhaust particles, they are the perfect weapon here. We can't see them, they're hard to measure. They carry hundreds of thousands of different harmful chemicals. We don't realize we're breathing them in all the time, and they get just the right size that they get right down to the bottom of the lungs, and then they get into our blood. Once they're in the blood, they actually start to build up in areas of disease where they're going to cause the most harm. And essentially what they do is they make us age, they inflame our arteries, they release chemicals which makes us age and causes inflammation. So I told you that was cheery. This is my token gesture to finish on a positive note. We do have the answer to this. The solution is quite simple. We just get rid of air pollution. We just don't make air pollution anymore. And we can do this, just as Adrian has been telling us, by participating in active travel, walk more, cycle more, use public transport if it's long distances. There is technology, and it is part of the solution. It's not the whole solution, Adrian, I do admit that, but it is part of the solution there. There is government policies that are happening now. We're having policies which hopefully will accelerate the change. It's not accelerating it fast enough, in my opinion, but we are getting there. We can design our cities so that we don't have to have long car journeys to go to the supermarket. We can have local cities where people can walk and cycle more. And we're starting to see changes with education. We're starting to see community projects. I speak to more and more schools these days who are doing air pollution projects, measuring air pollution, and raising awareness for air pollution. Even things like what we eat affects air pollution. So if you change your diet, it affects the air pollution that comes from farms, then that affects air pollution in our air. So it is positive. And if we can reduce air pollution, particularly air pollution from vehicles, hopefully that will improve our cardiovascular health. So I'll stop there. Thank you. Thank you. Thank you.
Hello, I'm Matt Bailey. I talk about salt in food, and I always get one of two slots. I get the slot before lunch or the slot before you all leave the room and go out and get something to eat. So I'm a professor of kidney physiology at Edinburgh Medical School, and I've spent most of my research career trying to understand how our body meets external environmental factors. And some of these are quite easy to understand conceptually. So for example, a couple of years ago, because I'm a romantic, I went skiing with my wife in Cairngorm, and it was -5 degrees outside. About 10 days later, I went to the cardiovascular hospital in Sao Paulo in Brazil, where I've got some collaborators, and it was 35 degrees outside. And that ambient challenge, that swing of 40 degrees C, changes my biology. So just to take one example, I sweat more to try and regulate my body temperature. It also changes my behavior. So for example, when I'm in Sao Paulo, I want to drink lots of water. When I'm in Scotland, I'll try and drink something slightly more concentrated. So that's really the concept of what I've been doing most of my research. But what happens if this environmental challenge is invisible? And so what I'm going to talk to you about for about 15 minutes is the salt in the food. And by salt, I mean sodium chloride. And we're going to cover these kind of 4 key things. I'm going to focus to start with on the little bit on the physiology. Salt is an essential nutrient. We can't get away from that. We need it in our diet. We do have this challenge of too much, a challenge of excess. What's the impact of that excess on health? And I'm going to end, I do end positively. Hang in there. It's going to be a positive message. We're going to give maybe some solutions and a little bit talk about where policy fits into that and where personal choices fit into that also. So let's start with the physiology. Salt is an essential nutrient. This is a guy called Homer Smith, a physiologist, professor of physiologist from New York University. He wrote this thesis in the 1950s that was essentially our evolutionary story, our journey from being fish to being philosophers is the story of salt. And the reason he argued that is that we know that we are essentially big bags of salty water, and we've got to get the concentration of the salt, the amount of salt in our body right, because that's what controls all the excitable tissue. So it controls how our heart beats, it controls how our nerves function. And we can see this with human disease. If we get salt wrong, your heart it has irregular beats, your nerves stop functioning. And the move from this kind of environment here, with the marine environment, to the terrestrial environment is taking our internal sea with us. And we must replenish the amount of salt that we lose. And that is a challenge, an evolutionary challenge, because here, as marine creatures, salt is abundant. It's all around us in the salt seawater. And once we adapt to life on land, salt is actually quite scarce. We don't think of this now, but historically and evolutionarily, salt is a scarce mineral. It tends to be concentrated in isolated parts. It's not very abundant and common. So the problem that we all faced was, the evolutionary challenge was that salt is a scarce resource. And this is a story about the evolution of solutions. So for example, if we look at our tongue, one of the 4 taste receptors is salt taste. So we've evolved receptors on our tongue that can taste sodium chloride above all other salts. It's really amazing machinery. We have pathways in our brain that drive salt hunger, so that when our body needs salt, we have an appetite to salt and we start changing our behaviors to go and seek out salt. And interestingly, these brain pathways are connected to the limbic system, the pleasure system. So when you eat the salt, you get a feeling of pleasure. Once the salt's in our body, we have a gut that is a very efficient processor of salt. It takes the salt from the food into our bloodstream really efficiently. And then the kidney, which filters our blood and gets rid of many of the toxins, is designed to reclaim 99.9% of the salt that's filtered. So what we've done over millennia is evolve solutions that allow us to find it, eat it, and keep it within our body. And this, you can see this kind of inherent value of salt. This is sort of entwined within our societies and our language. So, for example, we know, over 2,000 years ago, we were reading accounts of the salt caravan, mining it in Timbuktu, these isolated salt regions, and taking it to market. And these caravans still exist now. Salt tax has been a long means of governments to raise money. So there's a policy aspect to that. The salt tax built the Temple of Artemis, one of the wonders of the ancient world. But it's not just an ancient thing, because actually the Gandhi Salt March in the 1930s was in direct objection to the British taxation of salt, moving it from the east of India across to the west through the salt hedge. And overall, we have this idea in our philosophies that salt is this incredibly valuable thing, and if you are wasteful of salt, that's somehow bad and somehow evil. So this is a focus of a reproduction of Da Vinci's Last Supper. This is Judas Iscariot clutching his bag of gold, but here the symbolism is he's knocked over the salt cellar, and this very valuable resource is now spilled out on the table. And this is not just in Christian ideology, it's in most of the major religions have some concept of the covenant of salt. What's the problem? Well, the problem is now one of intake. So let's look back in our kind of evolutionary life. These are the kinds of salt intakes we had, about 0.5 gram a day, and that's what you need to replenish your internal sea. We know this from two things. We know this from archaeology. This is the kind of when we've gone into sites where there are evidence of ancient foods, and you can estimate the amount of salt from them. But perhaps more convincingly, there are remote tribes, the most famous of which is from this area of research is the Yanomami peoples. These are about 50,000 individuals in the Amazon rainforest that live this hunter-gatherer lifestyle, and this is what their salt intake approximates. This is the World Health Organization's maximum recommended intake, 5 grams a day. And I'm just going to pause there slightly, because one of the things I get asked often is, what does 5 grams a day look like? So for you people, I went back into the lab this week and got the sodium chloride off the shelf and weighed it on a scale. And my first effort wasn't that great. It's been a long time since I've been in the lab. But I got there eventually, 5 grams on the nose, and that's the photograph just to prove that it was me in the lab. But that really doesn't tell you very much, actually. It's just 5 grams of salt in a weigh boat. So actually, this is what I did here. I tipped it into this spoon, which for health and safety reasons, I must point out, is not the spoon that I use to serve my tea. It looks very similar to the spoon, but it is not that spoon. It's 1 flat teaspoonful of salt per day. That's what you should eat as a maximum intake of salt. But, and here's the but, we have this challenge of excess. This is the kind of the caveman diet. This is what I eat. And I've got 2 things up here. I've measured it twice in our experiments recently. This is 2016. It was about 9 grams a day. That's bang on Scottish average. And I was massively mortified by that, because I've been talking about salt for ages and thinking I was really healthy. And this is a measurement last year when it's gone down a little bit because I made some changes to the way I live my life. I'm going to flip that back to that right at the end. But the point is that I eat at least 16 times more salt than I need every single day. And I'm not alone. This is just taken from estimates of salt intake globally. This is the line of the WHO's maximum upper limit per day, and these are areas. Everywhere is eating more salt than the maximum recommended levels. And what's the health impact? So if we go to these hunter-gatherer societies through to the renal specialist who talks about salt but can't manage his salt, what are the health impacts of that habitual dietary salt excess? Well, they're quite extensive. We did an experiment, and the reason we did the experiment in mice is outlined here. They've got the same salt biology that we have. So the cardiovascular system is essentially the same. The kidney system is essentially the same. And what I can do with mice, which I can't do easily with you guys, is I can control the amount of salt that they eat, and I can monitor that over a long period of time. Now, there are attempts to try and do this with populations, but one of the challenges is if you ask people how much salt they eat, they always tell you that they eat around about 5 grams a day, and they don't, because people, me included, underestimate how much salt they're having. So this is a kind of very controlled experiment. We essentially gave mice crisps, and we measured blood pressure. We didn't really give them crisps. It was a proper diet. The way that you measure blood pressure is by this. It's called a radiotelemeter. It's a device that goes into the mouse under anesthesia. The mouse then recovers and lives a normal mousy life. And this is a radio transmitter. It's the same technology that beams engine stats out in Formula One, if you're interested. It means that the mouse can be doing its thing and all its blood pressure data come to me in a different part of the university. And this is what it looks like. So during this period of time, the mice had the kind of hunter-gatherer caveman diet. During this period of time, they had Matt Bailey high salt diet, and here we put them back on the low salt diet. This is blood pressure. The blood pressure goes up when the mouse is active, it goes down when the mouse sleeps. Your blood pressure would look very much exactly like that. Here's the high salt period, and look what happens. As soon as you put them on high salt, within days, within 2 or 3 days, blood pressure goes up, and it stays up. The good news is that when you change back to that low salt diet, blood pressure goes down. Now, that's mice. I always get the thing, well, that's mice. Yes, the physiology is similar, but the same thing happens in our closest living relative. There is a 2-year study in populations of chimps, one population in Africa, one in America, where they increase the salt intake. Blood pressure goes up with salt, but even after 2 years, if you remove the salt, the blood pressure comes back down. And there are some data in humans. These are something we pulled together looking at the clinical trial data. This is salt intake here. So, for example, that's 10 grams a day. That's our goal of 5 grams a day. And what you can find, the dark blue is a short-term clinical trial. The light blue is a longer-term clinical trial. There aren't very many of them because they're very difficult and expensive to do. But if you reduce salt, you can reduce blood pressure by about 5 millimeters of mercury a long time. And that's about the same, if not greater than, the effect that you can get from taking one antihypertensive tablet, just by removing that environmental challenge. It's not just about blood pressure. So the focus always on these talks is around hypertension, and that is a major problem, but it's not just that. Let me introduce 2 people. This is Dr. Hannah Costello, this is Dr. Jess Ivey. They're British Heart Foundation funded researchers in our centre at the university, and they've worked over a number of years on some great studies summarised here. What they're finding is if you have high salt intake, you get disruption in your normal circadian rhythms. This sleeping-waking cycle gets changed, not in a good way. You activate your stress response. Your basal level of stress hormones goes up. Your response to an environmental stress is massively exaggerated. This is sustained over a long period of time. It's not good for your health. And all of these things come together, and you've got high blood pressure and an increased heart risk. And of course, so for example, this has been picked up and it's something that people find interesting. And this is one of the big messages I'd like to say. Blood pressure is important, but it's not just about blood pressure. It leads to stress problems too. And research from other parts of the world is showing that actually it's accelerating dementia, it's accelerating cognitive decline independent of blood pressure. So what are we going to do about it? Well, the UK, this is where we talk a little bit about policy. The Department of Health and Social Care said reducing intake by 1 gram a day across the UK's population would be estimated to prevent 4,000 premature deaths per year. The quality of life stats are the same. If you could do this, reducing it from an average of 9 grams a day to 8, the benefits would be huge. Now, British Heart Foundation published a paper last year, policy paper last year, which was a modelling study. It was in the summer last year. And it was looking at the kind of health economic benefits, if you like, of reducing intake to that WHO level of 5 grams a day and saying what would happen if we could do this by 2030. It would prevent 180,000 new cases of cardiovascular disease, estimated. It would prevent 40,000 premature deaths. And I think one of the perhaps the most convincing argument when we go to policymakers is going to be this one. It would save the NHS an estimated £11 billion pounds by 2035. These are major positive outcomes for any economy. And the WHO themselves say that reducing salt intake is one of the most, it's along with the things that these guys have been talking about. It's not, actually high salt intake ranked lower than than air pollution in the league table. So we'll change that somehow. But no, what the point is that actually, this is a cost-effective way to improve health outcomes. So why don't we do it? Part of why we don't do it is that it goes back to our evolutionary thing. Our brains are encoded. We have a salt tooth. We want to eat salt. And there's an interesting thing from this BHF survey is that for quite a number of people that are aware of their diets in a way that they're reducing sugar and they're reducing fat intake, aren't achieving the same kind of cognitive awareness, if you like, when it comes to salt. So there's a biological context to this. But one of the big problems is about it's locked in our food. And I'm just going to focus on pizza, actually, because there's been a big thing last week about pizzas. This is a pizza that I picked up from my local supermarket, and it was their own brand one. Half a medium pizza contained 2.7 grams of salt. I can eat one of those myself. I don't know about you guys, but that is, it's a lot of salt. Now, the good news is that the UK had a salt reduction strategy that was governmental driven, it was non-legislative, and it was brilliant. It was truly world leading, and it removed 11 million kilograms of salt from food over this period of time. But it's broken. It's almost as if our politicians have been focusing on something else. And so, all of the targets are now, the regulation of the targets has been passed back to the food industry. And there's a report that just came out, is not only are the targets not met, we're regressing. So some of the foods they were focusing particularly on pizza in this are now containing more salt than they did in 2016. So we're driving backwards on this. And this is the policy change that can happen. It was brilliant, it needs fixing. There's personal action too. When I found out how much salt I was eating, it was like, okay, the best thing you can do is stop eating the salt. What's the second best option? Because actually trying to have a low salt diet is really, really difficult. But I've spent a lot of time in my own life trying to do these kinds of things, eat the lower salt options. Now, there's a challenge around this that I think the two challenges. One, there's inequalities. Lower salt options tend to be more expensive, and I think that needs to change. The other is that they taste different, and it takes biologically about 3 or 4 weeks for you to recalibrate how your brain perceives salt. But stick with it, because you can, and I did reduce my salt intake by about 1.5 grams a day, which is better than nothing. And my top tip, 2 slides. This is Atar Arshad. He's a BHF-funded PhD student in my lab, and he's found some cool stuff, actually. He's been focusing on potassium, and he's been feeding the mice with crisps, the equivalent of bananas. So if you give them, you don't do anything about the salt, but you increase the potassium, and the mice then pee out more salt and their blood vessels relax. Now, is that just mice? Well, I'd argue not. This is low salt. You can buy it at any supermarket. It contains less sodium chloride, more potassium chloride, and it's been used in 2 clinical trials, one in Peru, one in China. The Peru, 2,000 people, 3 years, this single intervention of replacing your normal salt with low salt reduced blood pressure by the same as 1 antihypertensive pill. Even more impressive was in China, a bigger study, and this was in high-risk people who already had cardiovascular disease. It found that if you did this single intervention in your life, which was putting this in your cupboards and on your table instead of your regular salt, it reduced stroke and it reduced death. So, on a positive note, when you go out for dinner tonight, don't worry perhaps about the salt so much, but have some bananas. Thanks for listening.
Thank you so much.
Across the UK and elsewhere is a really important starter for helping people to choose to travel actively.
Fantastic. So then may I just, the sort of theme for tonight's discussion was how public health policy can influence heart health. And we've seen examples where the policy is good, but we haven't quite got it into practice. If you had a politician now in front of you, what would you be asking them to do to actually ensure that this comes? And he's not got any money, I'm afraid. He can use a whip, but or she, but they don't have any money to give you to make this happen. What would each of you say now needs to happen? I'm going to guess actually getting the food industry not to self-regulate?
Yeah, so I think we had this right. I mean, the policy that was in place, that was put in place, it was developed sort of in the kind of late, through the noughties, if you like, was, I mean, it's lauded around the world as an excellent example of how you can achieve meaningful benefits without legislation, actually. And so what was worked on was identifying sequential reductions in food. So one of the big challenges for the food industry, and there's a famous story. It's a Campbell's soup. So Campbell's soup reduced the amount of salt in its tomato soup, actually, and it did it unilaterally, and it lost market share, like huge loss of market share, because it didn't taste as nice to consumers as Heinz soup, for example. And it was this big kind of that no one wanted to make the first step at reducing salt. But there's so much salt in our food that is unnecessary. It's not there for taste because it's super saturated. It's not there for preservation. So the sensible thing that the UK government did was saying, okay, how can we unilaterally move forward to reduce salt? And the kind of the teeth to that was that it was regulated and monitored and tested, and it had big fines if things weren't achieved. And I think the major problem was the removal of that and the passing of the regulation back to the food industry. The other thing is that we don't have estimates now of our salt intake on a population level. They stopped at the same time. So if I had somebody in here, I'd be saying let's dust off that policy because it was excellent.
Okay. Mark?
Goodness, where to start? So, I mean, the answer to reducing air pollution is already there, and the people have done the studies, and the fact is there was no one single thing. We need to do all those things that I sort of showed on one of my last slides there. We need to have the education, we need to have the incentives to reduce air pollution. If I had to say one thing for the politicians, though, they are currently designing new guidelines for particulate matter in the air. They are not potentially going to go as far as they could do. So I would say, instead of just meeting the minimum, try to go that a little bit further and try to do it faster as well.
And Adrian?
So I'd say one of the things we haven't quite touched on tonight, but was there in the background, was the role of industry, what we call the commercial determinants of health. So health is affected, as Matt's been alluding to, by the fact that industry doesn't want to really do less salt. Industry in terms of vehicle design doesn't necessarily want to produce more efficient vehicles which don't actually pollute our lungs. There's not, the dollar isn't in there. But that is one of the things that is really key to this. Now, if there is no money available, which is a bit of a tricky one, well, one of the things you can do, I'm involved with the Welsh Government at the moment because we have a rollout nationally in Wales on September the 17th for default 20 miles an hour. So Wales, anywhere that was 30 will become 20. There are exceptions, rule programs, you can have places that still remain at 30. But that's a big switch. It's a bit like changing the side of the road you drive on, all that sort of thing, which happen in other countries. So I'd say what we actually have got to do, we've got to have a big grown-up adult conversation about what is going on, and it probably could apply to all of our topics. A big conversation about the way we are living, the way that modernity is actually providing us with these choices, and we haven't used this phrase as well, but obesogenic environments, you know, eat these high energy dense foods, don't walk, don't cycle, get in the car and all the rest of it. This is making us ill. So we need to reflect on what we want for our children for the future and what do we want for our planet, because ultimately we've got to look after both, and that means we've actually got to change the way we live our lives. So I think a big adult conversation, showing people and talking the science to people is really important.
Last point.
Very brief. Yeah. I mean, the thing that has been, I guess, slightly disappointing to me over the years is that these adult conversations require politicians to be aspirational and to make decisions that will achieve benefit beyond their political lifetime. And the thing that's been disappointing is that there seems to be individually the will to engage in these kinds of things, but actually in terms of implementation, there's a step that fails there, because the benefits of this might not be unlikely to be visible by the time there's a next election. But 20 years down the line, you're looking at a much healthier Scotland, a much healthier UK.
Well, all that remains then is for me to thank you all very much for your time. It's been a really interesting talk. I'm going to hand to Elaine to close, but thank you very much on behalf of the Centre for Cardiovascular Health, the British Heart Foundation and the Association of Cardiovascular Nurses and Allied Professionals. Thank you.
I just wanted to say a few words just towards the end. How I love EICC Live Talks, because I learned so much in such a short space of time about so many different subjects. Thank you very much to Adrian and Matt and Mark. Thank you for coming along tonight and really enlightening us. And I think we're all going away inspired by the things that you've actually said tonight, and thinking ourselves about low salt pollution and how we're actually travelling as well. So thank you very much. I also would like to thank Lise as well for organising it all. And as we said earlier, it is all being recorded, so it is online. If you go and look at YouTube and you look for EICC venue, then you'll find it all there, just to refresh your memory and to get all those tips and links and ideas as well. One last final thing really is just to say, please don't forget about the British Heart Foundation at the back of the room, because as we saw tonight, they're doing fantastic work by supporting all the researchers with the work that they're doing. And finally, well, do keep your eye open on our What's On page, because there will be another EICC Live coming about sometime in the near future. And who knows what the subject will be then, but please do come back and see us then. Thank you very much and have a lovely evening.